Hello everyone, you are watching sqadia.com. Today, our lecture topic is the autonomic nervous system and visceral reflexes, and we are on the fifth and the last section of this lecture topic, that is the clinical correlates. We'll be briefly discussing some of the diseases which are related to autonomic nervous system and what are the effects on our body. We'll be discussing some details of Horner syndrome. What are the effects on the bladder if the blood's autonomic nervous system supply is actually cut, all the sympathetic and parasympathetic outflow is gone? What happens in the Raynaud phenomena and what it is, a Raynaud's disease and Raynaud phenomena, and what is the role of sympathectomy, that is cutting of the preganglionic sympathetic nerve fibers, in cure of Raynaud's disease. So what is Horner syndrome? It actually consists of mainly constriction of the pupil, which is called as miosis, dropping of the eyelid, which is called ptosis, anophthalmos, vasodilation of the skin because of this, and loss of sweating, which is called anhidrosis. All these symptoms result from interruption of the sympathetic nerve supply to the head and neck region. What are the causes which can cause Horner syndrome? These are different diseases. For example, it could be syringomyelia, it could be multiple sclerosis, it could be a cervical rib which is pressing on the cervical sympathetic ganglia. It could be impinging on the first stellate ganglia, first superior, middle, and inferior cervical sympathetic ganglia. Sometimes cervical actually impinges on the superior cervical sympathetic ganglia. This could be Pancoast tumor of the lung, that is, the tumor is in the apexes of the lung, and when it comes up, it causes a pressure on the sympathetic ganglia, first sympathetic ganglia in the head and neck region, and can result in the Horner syndrome. So what are the subtypes? There is actually a central Horner syndrome, a first neuron disease, then the preganglionic or second neuron disease, then the postganglionic or third neuron disease. As by now you are very well aware that what are actually the afferent part of the efferent part of the sympathetic nervous system. All those fibers which are actually bringing in information from the affected organ into the spinal cord are actually the afferent neurons. Once they synapse, from there onward there will be connecting neurons which reach the parasympathetic or sympathetic chain. From there, after synapses, the postganglionic fibers arise. So if there is a problem to the central area, there is a central Horner syndrome. If there is a problem to the preganglionic fibers, this is called as preganglionic, a second neuron disease. And if there is fiber after the synapses of the ganglia, then it is called the postganglionic, a third neuron disease. So this is an example showing a diagram of Horner syndrome. There are three things you can see: the dropping of the eyelid, which is the ptosis, constriction of the pupil as compared to this eye, this is called as miosis, and there is a loss of actually sweating, which is called as anhidrosis. But similarly, there is actually, as the sympathetic is lost, so the parasympathetic causes the dilatation of arterioles. So there is a flushing of the skin on this side of the affected side, resulting in hyperemia or of the flushed skin of the patient. Horner syndrome results when the cervical sympathetic pathway from the hypothalamus is interrupted. If it is interrupted from the hypothalamus, this is termed as central level. If it is interrupted at preganglionic level, then this would be termed as second neuron disease or preganglionic fiber. And once after the synapses, if it gets affected, is called as postganglionic tract, a third neuron disease. Now this is actually hypothalamus. These are the fibers which are coming in straight. If this tract is just going, if it's affected at this point, this is called a central neuron disease. But if the preganglionic fibers are affected, as you can appreciate over in this diagram, then this is called a second neuron disease. And once they have anastomose in any of the cervical chain, and then the postganglionic fibers are affected, this is called as third neuron disease. The clinical signs suggestive of the first neuron defect, central Horner syndrome, could include contralateral hyperesthesia of the body and loss of sweating of the entire half of the body. The signs suggesting of second neuron involvement would be preganglionic Horner syndrome include loss of sweating limited to face and neck and the presence of flushing and blanching of face and neck. Sign of third neuron involvement would be postganglionic include facial pain, ear, nose, or throat disease, The presence or absence of other localizing signs and symptoms may assist in differentiating the three types of Horner syndromes. So what happens if post-spinal injury to the unibladder? As we all know that the unibladder is actually being supplied by the sympathetic as well as the parasympathetic fly. What is the role of sympathetic autonomic nervous system? That it constricts the sphincters so that cause the relaxation of the bladder wall. But in case of parasympathetic, it dilates the sphincters, causes constriction of the bladder muscles so that a person can micturate. So innervation to the spinal cord is as follows. Sympathetic is from the first and second lumbar segments of the spinal cord. L1 and 2 are mainly supplying the sympathetic outflow, and this is actually parasympathetic is from this S2, S3, S4. That is second, third, and fourth segments, and then there are sensory fibers which are entering the spinal cord from the above segment as well. So urinary bladder is supplied by both the parasympathetic and sympathetic innervation. So if there's an injury at this level, for example, injury at L1, L2, only the sympathetic would be gone. Parasympathetic would be conserved. But if there is injury at the level of S2, S3, then there is chances that both the sympathetic and parasympathetic may be gone as well. The atonic bladder. What is atonic bladder? Atonic bladder occurs during the phase of spinal shock, when there is complete transaction of the spinal shock immediately following the injury, may last from few days to several weeks. Still, spinal shock is there, atony of the bladder may be present. The bladder wall muscle is relaxed, sphincter viscera is tightly contracted, there is a loss of inhibition from the higher levels, and sphincter urethra is relaxed. So actually it's the sympathetic type of a thing which happens. Actually the bladder wall muscle is relaxed, the sphincters are tight, and the sphincter urethra is relaxed. There is another called as automated reflex bladder. The automated reflex bladder occurs after the patient has recovered from the spinal shock and provided the cord lesion lies above the level of parasympathetic outflow. So what was the level of parasympathetic outflow? It was S2, S3, S2, S3, S4. So if the injury is occurring at L1, L2 level, since the descending fibers in spinal cord are sectioned, there is no voluntary control, the bladder fills and empties reflexly. Stretch receptor in the bladder wall stimulated as the bladder fills, and afferent impulses pass to the spinal cord, and eventually as it overflows, the sphincter opens and micturition occurs. Then there's a difference between automated bladder reflex and autonomous bladder. The autonomous bladder is the condition that occurs if the sacral segments of the spinal cord are destroyed. In case of automated bladder reflex, the injury was above the parasympathetic outflow, that is at the L1, L2 level. But in case of if the injury is at S2, S3, 4 level, then it would result in autonomous bladder. Or if that is the cord equina is severed, that is the bladder has no reflex control or voluntary control, the bladder wall is flaccid, and the capacity of the bladder is greatly increased. It fills to its capacity and overflows, which results in continual dripping. What is Raynaud's disease, and why are we discussing with sympathetic and parasympathetic activity over here? The Raynaud's disease is a vasospastic disorder involving the digital arteries of the upper limb, and it's highly painful. The disorder is usually bilateral, and the attack is provoked by exposure to cold. This is pallor cyanosis of the finger as well as a severe pain. Basically, there is a constriction of the digital arteries, and there is extreme constriction because of overflow of the sympathetic activity. This constriction results in ischemia of the digits, leading to extreme ischemic pain of the fingers and the toes. The gangrene of the tip of the fingers may also occur. In mild cases of the Raynaud's disease, the treatment is the avoidance of cold and no smoking, because smoking actually has a role in causing the vasculitis of these small arteries, accompanied by high sympathetic outflow. This actually compounds the fact, resulting in a severe form of Raynaud's disease. In more severe cases, the drugs that inhibit sympathetic activity, such as razorpine, bring about arterial vasodilatation with constant increase in blood flow to the fingers. Cervicothoracic preganglionic sympathectomy has been used, but the long-term results are disappointing. But why we are discussing in case of a very severe cases, sometimes you have to go for preganglionic sympathetic fiber sympathectomy. That is, you have to cut down surgically those fibers which are actually so that the sympathetic outflow can be minimized, and that would result in the dilatation of the already affected arterioles and small capillaries so that the blood can flow towards the digits. In this, the last section, we have discussed the clinical correlates. That is, we have discussed briefly the Horner syndrome. We have discussed what happens if the sympathetic and the parasympathetic supply to the bladder is cut. What happens if there is a complete injury or there is a partial injury, only the lumbar part is damaged or only the sacral part is damaged. And we briefly touched the Raynaud's disease, then what is the role of preganglion sympathectomy in case of the Raynaud's disease. Thank you very much. Keep watching sqadia.com.